Hello everyone, I am Dr. Anupam here and today I am in front of you with another important topic. Today we will discuss how to fix or how to troubleshoot a peak airway pressure alarm. Now this is very important in ICU because every now and then there will be some alarm going on, peak airway pressure alarm, peak airway pressure has become more than 40, what to do now? The sister becomes frightened, the sister calls a doctor, the doctor calls the biomedical technician, and it's a huge chaos. So today I will tell you a very simple method of how to troubleshoot a peak airway pressure alarm very easily. So let us discuss. Before going to fix or troubleshoot the peak airway pressure alarm, we have to discuss two very important concepts. One is called resistance, another is called compliance. Before going to the chalkboard, I want to say you something. Now consider the lung as being two units connected together. One of the units is the tubular structure, which is the upper airway, and another structure is the globular structure, which is the lung parenchyma proper or the alveoli. These two are connected. Correct? Now the thing is that the upper airway, when a airflow is going through it, it cannot expand. But the airflow has to overcome a resistance. Why the air flows? Because there is a pressure difference between the two ends of the tube. You remember from your physics class what is a ohmic resistor? An ohmic resistor is a straight tubular wire through which current flows, and the potential difference between the two ends is equal to current flowing through it into resistance. We will apply the same formula here. Please keep your attention. So first is resistance. Resistance, by definition, it is opposition to air flow, right? Opposition to airflow. So as I told you, we can consider the lung as two units. One is the upper airway or the conducting airway, and another is the lung proper. Okay. So now while we are talking about resistance, we will be discussing about this part. This can be compared to ohmic resistor. What is the ohmic resistor? Ohm's law tells that in a conducting airway or in a conducting wire, the potential difference between the two ends is directly proportional to the current flowing through it, and that proportionality factor is the resistance, or V is equal to current into resistance. The same formula will apply here. How the air will flow in the airway? Because there is a pressure difference between the atmosphere and the inside of the lung. So there is a delta P here. Here is a pressure P1, P2, and air is flowing through it. It is a flow. Because it cannot expand outwardly, so it has to survive a resistance that is coming in its way. So the resistance can be told as delta P by flow, and this delta P is called driving pressure by flow, right? So this is the driving pressure that drives the flow from one end to the other end, and while the flow is going from one end to other end, it has to face the opposition of the resistance. That resistance can be defined as delta P by flow, driving pressure by flow. Or in simple words, we can rewrite this as this pressure in the upper airway is equal to resistance into flow, right? So remember these things from here. Then another important concept we have to discuss is compliance. Now when we are talking about this globular structure that in the beginning we were discussing, this globular structure is different. When you put some volume inside it, or when you put some pressure inside it, it will increase in its size, not longitudinally but radially. So all the resistance is dissipated. So what is important here? Whether it can expand or not. So the elasticity comes into factor. So this is called the compliance. So what is the compliance? So second thing we will discuss is compliance. of the structure. Now when you apply pressure to it, it will elongate. It will elongate to different radial areas. It will become like this. It will become bigger. Initially it was like this, bigger. So the compliance is, so what is compliance then? The formula of compliance will be change in volume from here to here divided by change in the pressure. Correct? So now what is the change in volume? That will be the tidal volume that you are applying to the patient. And what is the pressure? That will be, because PEEP is always there inside it, and we are applying, there is a pressure created inside the lung, that is called the P plat. So delta P will be P plat minus PEEP. Correct? Right? So now from here we can calculate P plat minus PEEP is equal to TV by compliance, or in other word, P plat is equal to TV by compliance plus PEEP. It is another formula, or it can be called as pressure that is due to compliance of the lung. Now it is clear to all of you that there are two kinds of pressure we are dealing with. One is pressure due to resistance of the upper airway or the conducting airway. Another is pressure due to compliance, that is of the globular structure that can only expand radially, where the elastance or compliance comes into play. So now coming to troubleshooting, so we can have one definition: peak airway pressure is equal to what? Pressure in the conducting airway, or it can be called as pressure due to resistance plus pressure in the lung parenchyma or alveoli, or it can be called as pressure due to compliance. Now rewriting these two things in a very simple way, and this is called the equation of motion also. Peak airway pressure is equal to pressure airway equal to resistance into flow plus pressure due to compliance can be rewritten from here. It is P plat, or can be rewritten as tidal volume divided by compliance plus PEEP. This is a very important formula all of you have to remember. This is also called the equation of motion. What is this called? Equation of motion. Now we'll discuss what are the factors that can increase this peak airway pressure, right? Each and every factor can increase the peak airway pressure. We'll discuss one by one. First is resistance. Okay, so the resistance of the airway can determine the peak airway pressure. For example, you have a ET tube and you have selected the ET tube a very small size. Then what will happen? Resistance will become very high. or there is some secretion, clot, or there is some kinking. Correct? So how otherwise resistance can increase? By bronchospasm. So there are methods. So we will use the Poiseuille's formula while applying for this resistance, and that will be, what is the Poiseuille's formula? Resistance of a structure, tubular structure through which laminar airflow is going is proportional to 8 NL by R to the power 4. So directly proportional to the viscosity. This is the viscosity, this is the length, this is the radius. So the striking feature is that radius is to the power 4. Correct? So that means if you have chosen a small size of tube or in a prepared size of tube, even 1 centimeter small, it will increase the resistance 4-fold. So we have to be very careful while selecting your tube size. Never choose smaller size of tube because it will increase the resistance 4-fold and increase the peak airway pressure because it's directly relation. So what are the other things? For example, if there is clot in the circuit, the clot in the circuit can compromise the radius, can increase the peak airway pressure. Or there is kink. Kink can decrease the radius, increase the pressure, increase the resistance, increase the pressure. Or there is secretion, right? So all these things can increase the resistance and increase the peak airway pressure. Secondly, bronchospasm. If there is bronchospasm beyond the tube, in that situation also, the radius of the conducting airway will decrease, and that will increase the resistance 4-fold, and that will increase the peak airway pressure. Another, length is not such a big factor when you are choosing a endotracheal tube because almost all of them are of equal or just little bit of different size, but not too much. Viscosity, if you use viscous gas, it will increase the resistance, increase the peak airway pressure. So sometimes you use nitrous oxide in air dispersion to decrease the airway resistance, right? So this is the first thing. Second is flow. If you have set the flow inappropriately high, if you have set the flow inappropriately high. Now one thing you have to remember, the flow is fixed. When you are setting the person in volume control ventilation, you have set the flow. So the flow on itself cannot increase the peak airway pressure. It is for other reason the peak airway pressure will increase, and flow will only contribute to make it look bigger, look larger. So do not come down on flow when peak airway pressure is high. Find out why otherwise the peak airway pressure is high. Correct? And third will be coming to here, flow if discussed, resistance, then tidal volume. If tidal volume is set inappropriately high, right? Again, like flow, the tidal volume we have set from the beginning, so it cannot on itself produce a high peak airway pressure. Rather than the other factor like resistance can produce high peak airway pressure, and it can contribute and make it look larger, the peak airway pressure. So do not temper on tidal volume or flow in the beginning. First try to fix the resistance or the compliance problem. So the fourth one will be very, very important. That will be compliance. Compliance is inversely proportional to the peak airway pressure. If compliance increases, the pressure will decrease. If compliance decreases, the pressure will increase. So what are the conditions where compliance will decrease? Compliance decrease means the lung become more stiff. It's less compliant means more stiff. For example, a fibrous lung. Correct? So what are the conditions in which suddenly the compliance will decrease? and the peak airway pressure will be high. This is very important. There are few conditions you have to remember on emergency basis. One is pneumothorax. Pneumothorax can decrease the compliance of the lungs suddenly, or pleural effusion, or pneumonia, pulmonary edema, hemothorax. All these things can in an emergency basis decrease the compliance of the lung. The lung cannot expand too much. So that will increase the peak airway pressure, because it is inversely proportional. If compliance decreases, it increases, right? So these are the few things you have to remember. Another thing will be there, endobronchial intubation. Endobronchial intubation. Last but not the least, it will be the PEEP. If it is set inappropriately high. Again, like resistance like tidal volume, PEEP also same thing. It cannot suddenly increase the airway pressure too much, but it is the other thing, the resistance in the compliance factor, that will start increasing the peak airway pressure, and it can compound it like resistance, like flow, tidal volume. The PEEP can compound it and make it look larger. So do not first try to fix the resistance and compliance component. So these two things are very important. The compliance factor and the resistance factor. These two things you have to very clearly look in the ventilator when there is a peak airway pressure alarm. Otherwise you can go down this equation one by one and see what is the problem in my patient. Now if there is a problem, you can differentiate this peak airway pressure equation into two parts, but that you can only do if patient is paralyzed. If patient is paralyzed, sedated, and you are giving a tidal volume 8 ml per kg body weight and using a square wave flow pattern, if these are the conditions satisfied, then you can put a PEEP inspiratory pause of 0.5 second. When you put like this, you will find a graph like this, the pressure time scalar. Correct? So this is the pressure time scalar. So this is the peak airway pressure, this is the P plat, and the difference is called the driving pressure, or the pressure that is responsible for the flow to go from one end of the conducting air to the other end. This is the driving pressure, the difference between the P airway and P plat. So when you can differentiate these two things, so you can cut this equation into two parts. Now if you find the driving pressure is normal, then this part is taken out altogether. So there is no problem in the resistance of the airway. If you find the P plateau is actually normal, but P airway is high, so this part you can remove, right? So if you rewrite the equation, resistance into flow plus tidal volume by compliance plus PEEP. So if you put an inspiratory pause, you can differentiate, you can just differentiate these two things, right? This is the differentiating factor. If the driving pressure is normal, this is the driving pressure, difference between this. If it is normal, then this resistance into flow is not contributing to peak airway pressure. However, if it is not contributing, then who is contributing? This is contributing to peak airway pressure. So your differential become narrowed down, right? In otherwise, if the P plat remains normal, that means what? This TV by C plus P, does not contribute to peak airway pressure, right? So what is left? R into F. So here the cause of peak airway pressure high will be the resistance component. So in this way you can just divide these two things, but provided the patient is paralyzed, sedated, and you are giving a Tidal volume 8 ml per kg and you have a square wave ramp form. Otherwise, if patient is not paralyzed, we can just follow this formula and one by one we can see and decide what actually contributing to the increased airway resistance of the patient, and accordingly you can treat it. For example, if it is a small size 80 tube, we can increase the size of tube, we can put another tube of bigger size. Clot secretion can be removed. Kink can be taken care of by using a oral airway. Bronchospasm, nebulize. Viscous gap, use nitrous oxide as an ARDS. If compliance is decreased, then you have to find out why. Do X-ray. If it's pneumothorax, put a needle. If it's diffusion, put a needle. Pneumonia, give antibiotic. Pulmonary edema, give Lasix. Use a moderate PEEP. Hemothorax, drain. Endotracheal intubation, just remove the tube. So these are the things that you have to take care when you are dealing with how to troubleshoot a peak airway pressure alarm. If you go one by one, I am 100% sure in the next patient you are going to treat it, you will do it absolutely wonderfully. Thank you very much.